Good morning. I am Dr. Cheryl Martin-Schild, your LERN Stroke Medical Director. I would like to introduce Laurie Schluter to present our first webinar on the neurological exam and common stroke syndromes. She is a Louisiana native who is a family nurse practitioner with fellowship training in NetSmart as an advanced neurovascular practitioner. Laurie is a board member with the Association of Neurovascular Clinicians. Laurie, take it away.
Good morning, everyone. This is Laurie Schluter. Thank you so much for attending the talk. I'm going to be talking about the NIH stroke scale and how to localize stroke syndromes based on your exam. I've also included my email at the bottom of this slide if you have any questions after viewing the webinar.
So what we're really talking about today is when you do an exam, how it can help you figure out what the findings really mean and possibly where in the brain the problem is. So I know this is quite a busy slide, but what it is showing you is considering where you're testing with what you are doing. So each part of the brain does have a special function, and based on where these functions are normally located, how the regions of the brain are connected, and which arteries provide flow to which parts of the brain, patterns of loss of function can occur during and after stroke. This represents common stroke syndrome. Fortunately, there is some degree of redundancy for most functions and some ability to recruit brain regions to do more than they actually did before the brain injury. Therefore, improvement in a patient's function after a stroke is very possible. When you really break down what's going on with someone's brain, it's very often thought of as far as left and right-sided functions. By looking at this, you can see that the left hemispheric functions, which generally many of us think about most seriously, would be what we call language skills, is how we're able to communicate. Sometimes math can be a part of this, and this really is about exact calculations and our literal grammar of how we communicate. The right hemispheric functions are more related to things such as our intonation when we speak and maybe the rhythm of our speaking. And as far as numbers are concerned, it's more of approximate calculation. I think one thing important to note too is if a patient tells you they have a history of a stroke on the right, they may be talking about the fact that the right side of their body was paralyzed after, so you have to use your knowledge to know that the left side of the brain may have been what was actually affected. I also included some imaging here that shows you the blood vessels and how they relate to these areas of the brain that we are speaking about, because that's really how it all goes about. We do have to keep in mind that not everyone's plumbing is configured as the textbook says it should be, but in general this should give us an idea, and of course later on we will get imaging on our patients to find out how they are actually configured. So these are some of the arteries that we can start thinking about as we discuss this workup. So most of this is going to be based on the National Institute of Health Stroke Scale, which is what NIHSS stands for, if you ever wondered. This is a standardized method that we use to measure impairment caused by a stroke, and that's one of the really good things about it. It's quantitative, it's systematic. 5 different people should be able to walk in the room one after another, and as long as the patient didn't have any significant change, they should be able to get the same score. It should allow for objective comparison this way, and it's used in emergent treatment, but it's also used later on with most research and explanation of patients' outcomes and how they do during their stay. Many of the EMS providers are probably more familiar with shorter exams such as MEND and FAST and Cincinnati Stroke Scale, and they do have portions of this within the NIHSS, but I think it would be good for you to have an even greater understanding of some of the things we're looking for and what we're going to do the minute the patient gets to us in the emergency room and some of the questions we may be asking. So when you score it, the point is the higher the score, the worse the deficiency, and usually the worse the stroke. So if someone's stroke scale is greater than 20, they have a really concerning stroke. It is important to note that on this scale, it's reported that 0 to 4 is a mild stroke. This is up for debate among some people because, as you'll see as we move along, if someone gets a 2 for the language section of the scale, that would mean that they really can't communicate, and I would consider this a very serious disability, and this would not be considered mild for me. So I do believe that the higher the number, the worse the stroke, but sometimes a low number could still be a very disabling situation for a person. And it's also important to note that 0 does not mean they do not have a stroke, and you will learn more about this as we go further on. So I'm going to go through each part of the stroke scale just as a review for some of you and as learning for some of you that are not familiar. So it really starts with the level of consciousness, and the first one is called 1A because there are 3 sections of level of consciousness. And really what you're looking at is whether or not the patient is alert, drowsy, stuporous, or comatose. So alert, I think, is pretty self-explanatory. This is the person that's totally interactive with you, responds to everything you say to them, and is what probably, hopefully all of us are right now. One they put as drowsy on the stroke scale, and it's just important to really talk about the word drowsy because you may walk in a patient and ask them how they feel, and they may say drowsy, and that may not be the same definition that we're using. We've all felt somewhat drowsy, but that's not really what we mean with the stroke scale. It really means someone that it's harder to keep their attention, and you may be able to arouse them. They can answer all your questions, but then you may turn around and they're really not responding and interacting and engaged with what's going on with them. When you get to a 2, that's when we consider stuporous or sometimes obtunded, and this means you've got to really vigorously stimulate them to get any sort of response, and you're not going to maintain any responsiveness for long. And then 3 is what we consider comatose, and the only type of response you're going to get is what's called a reflex. So this may be someone who is posturing and having some type of reflexive movements that are not something that are in relation to really what you're doing to them. So some of the strokes that would affect level of consciousness would be things that would affect our reticular activating system. And these would be things that affect the posterior area of our brain, such as basilar artery occlusions and strokes that affect the brainstem and the ability for us to be alert and awake and interactive. Also, if someone has bilateral cortical dysfunction, meaning they've got strokes on both sides of the brain, it's really hard for them to attend to what's going on around them and be able to interact and have purposeful interaction. They also could have some type of systemic, one of the most common being a seizure that could cause this, but you do want to keep in mind that seizure at the onset of stroke is very common, so just because you think someone told you there was a seizure or maybe you witnessed a seizure, it doesn't mean that stroke is not part of the process. They also could have overdosed or be toxic for other reasons such as dilantin levels and really metabolic reasons, multiple other reasons. And then hemorrhagic strokes are something that affect level of consciousness right away. When patients have bleeding in the brain, they have a sudden area where there's blood trying to take up space, where there's often not any space to be taken up, and their ICP will elevate or their ventricles will be blocked and have obstructive hydrocephalus affecting their level of consciousness. So these are things that could affect those points. The second part of level of consciousness, called 1B, is 2 questions that you are recommended to ask the patient. You want to start with what month is it and what is your age. And you are supposed to ask the patient in this order and take the first question. Since this is a standardized test, there are times where they may say, oh, it's January, maybe on February 3rd, and then very quickly be able to correct themselves. But you still score them, but you can make notes later on that you think that they were just kind of not keeping track and able to tell you. The point of this is to see can they answer these 2 questions, and the way you score them is based on how many questions they get correctly. Now, if someone is intubated or has any other type of mechanical blockage to their mouth and ability to speak, they do automatically score a 1 on this, and that's important to note. Some things that could make you unable to answer these orientation questions regarding the stroke would be a frontal stroke, which could affect their memory. They also could have language disorders, which are aphasias in the Broca's area or the Wernicke's area of the brain. They also could have non-stroke issues that are going on, such as some type of underlying dementia or delirium going on, and you may find out more during your history of the patient that this patient has dementia and rarely knows what month or what their age is in the first place. The third part of level of consciousness is, can they follow commands? The two commands that you should show them is, or ask them to do, is to open and close their eyes and to make a fist and then open their fist. You want to obviously choose the side that's not paralyzed if they do have a paralyzed side, if they are able to do this. If they're able to follow both commands, they score a 0, but depending on how many commands they're able to follow, you score them. If the patient doesn't seem to understand what you're saying to them, you can then move on to mimicking these two functions and see if they are able to follow these commands by opening and closing your own eyes. Also, you could do this if the patient was deaf. Some of the reasons they're unable to follow commands would be that they might not understand what you're saying to them due to a language dysfunction due to a stroke, and this is usually the Wernicke's area of the brain. Sometimes when they have strokes that cause inattention, they may not be able to even pay attention to what you're saying to them enough to take it all in and be able to follow the command or complete the task. And sometimes you may say something like make a fist and they might hold their hand up but not actually complete the task. And sometimes they can't actually execute the movement because they're paralyzed or they have an apraxia that causes them to be unable to do the actual movement. So after the level of consciousness section, we move on to gaze, and this, of course, is related to cranial nerve function. And the most common type of gaze affected by stroke is horizontal gaze, so that's why that is what's tested. So what you're having them do is you're holding your finger up and you're asking them to follow your finger as you move it from side to side. Sometimes people's eyes are fixed to one side, like the poor guy in the picture we have right here, and that's what's called a forced gaze deviation. Many times their head is going to be turned to that side, and you practically have to lean over and bend over to talk to them and have any type of interaction with them. And no matter what you try to do, you cannot get their eyes over, even if you move their head, which normally considered an oculocephalic maneuver could move their eyes. Of course, if there's any concern for neck injury or trauma, you would not attempt something like that. Moving down to the one where they get 1 point, that's called a partial gaze palsy, and often we call this a gaze preference, where their eyes may be kind of to one side, but they are able to start to track you across the room, and they generally will bounce right back to the side, and they're usually unable to pass the midline. You may also notice when you're doing this that they don't have any vertical movements of their eyes, and of course this is an important assessment, but this would not score on the actual stroke scale. Things that would affect their gaze would be some of the bigger kind of strokes that we worry about and what we call large vessel occlusions. So the MCA strokes, which is the middle cerebral artery that we looked at on the picture earlier, where their eyes will go towards the lesion of the stroke. This means that they're actually looking away from the affected side. So if they're paralyzed on the right side, their stroke may be on the left side and their eyes are looking towards the left. Some people like to remember this by thinking it's way too depressing to look at the paralyzed side, so they look away from it, and it's an easy way to remember it. A PCA stroke could also demonstrate a gaze effect, and it's sometimes the preference because they have a visual loss on that side or some type of neglect in their visual function that causes them to have a gaze to one side of the room. Sometimes patients actually have what we call a wrong way gaze, where the eyes are deviated to the same side of the stroke. Many times we decide that this is a seizure because the eyes do usually go away from the lesion in a seizure, but this can also be strokes of the brainstem of the midbrain or pons, so we don't rule out a stroke because of this. So the main thing to remember is any type of gaze abnormality, the patient should be worked up for stroke. We're still talking about the eyes here, but now we're talking about visual field testing. When you look at this, it's got some kind of a lot of words on it, but really the breakdown of it is peripheral vision. What happens when the people lose their visual field, and it's called a visual field cut or homonymous hemianopsia or quadrantanosia, it means they lose the peripheral vision on one side of the room. Don't be surprised if the patient who loses peripheral vision on the left side of the room comes in and tells you that they can't see out of their left eye. This is generally how they perceive it, and that's why it's important for you to cover one eye at a time and test each visual field usually by moving your fingers around in the visual field to see that it is both eyes, and sometimes help them understand that it is both eyes. You want to make sure that you're standing in front of the patient and that when you have your arms out to the side that you can actually see your eyes in the peripheral vision, because if you can't see it, it's probably not in their peripheral vision. And you want to be close enough to the patient that you're not standing so far away that they can obviously see it anyway. The way I do it is I ask them to look me in the eye, and I lock eyes on them. That way, if I notice any sort of movement, I try to redirect them. And I have them do things such as point to where my fingers are, or they can tell me what side it's at. Really, whichever way you see that works for your patient and engages them in the test is the best way to do it. Certainly, if they can't talk, you would ask them to point. Or sometimes they may not be able to really participate completely in the test, and what you can do is something called a blink to threat test. What you would do is really just wave your hand in that visual field and see if they blink, or they may even look towards it. And this goes to show you that they do actually see something over there. It's as if there was a fly in the room and you keep seeing it out of the corner of your eye. You just have to be careful when you do this that you don't move your hand with such force that it causes a little bit of wind to go towards their eye, because this would cause someone to blink whether they have vision or not. Another thing important to note on this is if they are blind in one eye, you only test the eye that has vision, and it doesn't play a part in the scale. Some of the things that would affect our visual fields are some of our large arteries, such as the middle cerebral artery and the posterior cerebral artery. I'm concerned that this is a large vessel occlusion when patients do have a visual field cut. Moving on to facial paresis, I think that sometimes is one of the more common things and one of the more obvious things, and even one of the things that the family will tell us right away that something's wrong with their face, or even the patient sees themselves in the mirror. But it's really based on how much of their face is affected. When you score a 1 on someone, that's the one that you really have to look for. So you may be asking them to smile or show you their teeth, or whichever way you can get them to move their mouth in a way that you can look for symmetry. And so you may notice that their lip doesn't move over their teeth the same way it does on the other side, or if they have smile lines or wrinkles, you may notice a change in that. The more common thing you're going to see with stroke is a 2. This is the person that you look at and immediately you can tell something's wrong with their face. And then 3 means they have a total paralysis, including the upper face, which is not near as common. And the next slide shows you some pictures of this. So the gentleman up at the top of the screen wearing the blue shirt, he is what you would score a 2. And the gentleman at the lower part of the screen is what you would score a 3, where he can barely even close his eye, as you can see. There are some strokes that will cause facial droop and will spare the forehead, and these are more common and they're not always easy to localize. So it's really just more important to notice this and document about it. So you can see that it can be cortical areas, which would be more of the essentially the gray matter, and then subcortical areas, which are essentially the smaller vessel areas and the white matter. And then there are times with the one that's listed at the bottom where they can also have involvement in the forehead with an area in the brainstem. The next section is the motor function of the limbs. So I'll put this all together because it just makes more sense to talk about it all together, but you test their arms and their legs. The patient should be laying down, and for their arms, you want to put their arms at 45 degrees supine, and I think the smartest way to do it is for you to literally lift up their arms and get it to that level. What I'll find patients will do if they're weak is they tend to go higher than 45 degrees because they're hinging upwards with their shoulder and they're not really fighting gravity the same way. So you bring their arms to that level and you see if they're able to hold them at that level equal for 10 seconds while you count to 10. And you can count up to 10, you can count down to 10, you can maybe have the patient participate in counting, whatever you feel works for you. You're looking to see if there's any sort of movement with this. Any sort of drift? Can they make it the 10 seconds? Does their arm immediately drop? Or is there no movement whatsoever? When you do the same thing with the legs, it's at 30 degrees, and you only do it for 5 seconds. And for the scoring of this, it's all about what we call drift and anti-gravity. So if they have any sort of movement or what we call a bobble sometimes, or if they're slowly moving down but don't hit the stretcher before you count to 10, that is a 1. If they do have some ability to hold it against gravity, but they hit the stretcher before you hit 10 or 5 on the legs, then they get a 2. Now, sometimes they may be able to move their hands around or adjust their limb, like with their shoulder or muscle movement on the bed or stretcher, but they are not able to do anything against gravity. They're not able to get it off of that surface. That would be a 3, and 4 is when there's no movement at all. There is a section for untestable for this, and because of the fact that they can't move doesn't mean you put untestable. Untestable really only comes into play in infrequent times, such as amputation of a limb, and really for the leg, probably more so in AKA. You can probably still test them if they have a BKA. If they have a joint fusion, if they just had a hip replacement and the doctor has said do not move their leg, if they have a restraint that's on that you cannot remove for any reason whatsoever and you decide it's not a good idea, that's when they would be untestable. The strokes that affect motor function are, again, sometimes these large artery strokes. The MCA stroke commonly affects the face and the arm. The anterior cerebral artery more commonly affects the leg, and that's one way to differentiate between the locations. And it's usually contralateral to what side of the brain the lesion is at. Even though this can look like a large artery stroke, sometimes it is a subcortical stroke, so it is another one that can be poorly localizing. If the patient does have weakness on both sides of the body, you don't want to decide that it's not a stroke. Of course, it could be like a spinal injury or something else, but the basilar artery occlusions can cause quadriplegia or tetraplegia, and you should certainly look into that and look into that vessel. The next section is ataxia. The things that we do is we test what we call finger to nose and heel to shin testing. You literally have them take their finger and touch their nose and then reach out straight in front of them where you should be holding your finger and see how straight the line is. If they wander all over with their extremity, that is what we call ataxia. Similarly with the leg, you have them take the heel of one leg and put it on the knee of the other and slide up and down. If their leg is literally flopping all over the place, you would suspect they're poorly coordinated. And sometimes by comparing one side of the body to the other side of the body, you'll really notice that something is not right. You want to test with their eyes open. And if they do reach out fully, you want to make sure your finger's far enough away that they stretch out all the way. But if they do start to have a tremor when this happens, this does not count as ataxia. It is an abnormal finding, but it's not ataxia. For this test, they get a 1 if they have it in one limb, and they get a 2 if they get it in 2 limbs or more. And you might have them have it in 4 limbs, but they still only get a 2 because there is no score of 3 or 4. It's important to note if they're unable to participate in this testing, they get a 0. This is one that is assumed normal if they're unable to participate. So if they do have a paretic limb that they cannot participate, you give them a 0. There is a section for untestable, but again, it's just like motor, where you can't test them because of something like a contracture or amputation. If they are weak in a limb, and say it's slightly weak, it may be hard for you to tell if it's a weakness or if it's really truly ataxia. So you want to think about how weak were they on their weakness exam and motor exam to decide if the score goes for ataxia or the score may go for motor. And sometimes you may score for both. The strokes that would cause ataxia are generally most commonly the cerebellar strokes, but it also could be a posterior cerebral artery stroke or a brainstem stroke. The next section is sensory, and the way to test this for the stroke scale is to use some type of sharp object like a pin or the edge of a paper clip, and you want to compare left to right. You should be testing their face, and you can even do things like forehead, cheek, and chin, testing their arms, which is ideally the forearms, and testing their legs, which is ideally just above the knee. Now, certainly if you're testing a patient out in the field and they're wearing pants, you may not be able to get in there, so you can test somewhere near the calf if you feel like it's safe for you to reach up into their pants. But that would be the ideal way to test it. It is recommended that you don't test the patient's hands, and this is probably a way to avoid mistaking neuropathy for a sensory loss. What you're looking for is symmetry, and are they able to feel you at all, and is it equal on each side, and that is how you score them. Some strokes that would affect sensation are the large MCA strokes and ACA strokes, but some of the small vessel strokes can also do this. And usually all their sensory loss is on one side of the body, which could affect any of the three places, face, arm, or leg, or any combination of that. But you can have it where it is crossed, where their face could have sensory loss on one side and their leg on the opposite side, and it's really localized to the medulla. The next section is what we call language. They do call it aphasia on the stroke scale, and you do have to be careful about this because just because they get something wrong on this does not mean they're diagnosed with aphasia. But I like to use the word language for this. So things you're testing is fluency, naming, repetition, comprehension, and reading. And ideally, you should also test writing, but this is not always available to you in an emergent situation. If someone is mute, but they are also able to follow your commands, which makes you understand that they are having some comprehension, you do go ahead and give them a 2, even though 3 says mute. I'm going to skip ahead to what we use for this, and then we'll talk a little more about scoring. So fluency is having this picture and having them fluently describe it to you. Can they look at it, pick out what these things are, and use the words using phrases and sentences that are fluent? You may learn other things about the patient, that they're confused, that their vision is a problem, but what you're testing for is fluency. For naming, you ask them to name these objects, and the goal is that high-frequency words would be glove, key, and chair, and lower-frequency words that are not as commonly said would be cactus, feather, and hammock. And you see if they're able to name the objects and how many objects are they able to name. If a patient is blind, you could do something like taking a key out of your pocket or a pen out of your pocket and putting it in their hand and see if they're able to name it. You do have to take someone's vocabulary into hand with this. I do find that many of the patients that come to our hospital don't know what a hammock is. They tell me it's a swing. They've never heard the word hammock when I tell them, but you still would score them because that is a standardized test. Repetition is the next session, and you ask them to repeat these words. They go up in syllables, and they use different sounds, and you see if they are able to use the functional things they need to use, such as their lips and their palate and their tongue, and clearly speak these words. And also, can they repeat them after you? And then the last thing is these simple sentences. You have them read to you, and if you see, they get more detailed sentences. You also may learn that they have a visual field cut where they say the last word of each sentence. But that's not really saying they can't read, it's just they can't see the other side of the page. So when I go back to the scoring real quick, obviously they have to get everything right to get a 0. Mild to moderate is a pretty wide area there. So really if they miss 1 or 2 things, you may say mild to moderate. We really only start saying severe when they're unable to participate with the exam. You can tell they can't understand anything you're saying. And then certainly if they're mute and do not interact with you at this, they get a 3. The next, strokes that affect language, most known for this is the left MCA stroke, but this can also happen from the left ACA stroke. So really things that affect the left side of the brain, period. Again, on that note, the left PCA stroke has been known to be an MCA mimic. So the biggest thing to take away from this is it's probably a left-sided stroke. They may also score points on language because they might be confused, they might be really inattentive, they might have dementia or have trouble with their cognition and cannot answer the questions for those reasons. And I mentioned before a visual field cut or visual neglect may affect their ability to look at these things. The next section is dysarthria, and this is clarity of speech. Are they slurring their speech? And the section that you used where you had them repeat the words, the repetition part was for language, but the sound of the words and what you heard when they said these words is how you scored dysarthria. Again, 1 is a pretty broad area of how mild it is or how serious it is, but severe, we only really score them that when we can't understand them or we have to ask them to repeat themselves at least half of the time. If they are mute, they automatically get a 2. If they are intubated or have any other mechanical barrier, say their mouth is wired shut, or even if they have a trach without a passing mirror valve, they would get what's called untestable and get an X for this. Things that would affect the quality of speech could be all areas of the brain just about, and it's really poorly localizing, but it's just important to note and ask If you do notice it, a lot of our patients have very strong accents. They may have poor dentition affecting the quality of speech. And so if they have a loved one with them, you may ask them, how does their speech sound to you? And it can give us more information. And then the last section of the stroke scale is what we call neglect. It's kind of a negative word, but what it really means is that the brain neglects an area of the brain, or an area of stimulation that they are unable to overcome double simultaneous stimulation. So what that means is when you are doing the visual field testing, the last thing you should do is put both of your hands in the air in their peripheral fields and ask them which hand is moving, and move both the hands. If they only point to the right one, you suspect that they have what's called left visual neglect, meaning they saw it when only one of them was there, but when both of them was there, their brain is unable to recognize visually what is on the left side of the room. For sensation, you do essentially the same thing when you do their sensory exam. So at the end of their sensory exam, you have, while their eyes are closed, you would touch the right side. They may tell you you touched the right side. You touch the left side. They tell you they touched the left side. And when you touch both sides, hopefully they say you touched both. But if they don't, then you know they have neglect. Now, obviously, if someone has dense sensory loss, you can't test for this. If they have a complete visual field cut, you can't test for this. And you would assume that this is normal in this case and score them a 0. You can test for visual and sensory neglect, but they can have other types of neglect that you don't officially test for on the stroke scale. Some of the strokes that cause neglect, most commonly going to be a right-sided stroke, most commonly the right MCA or PCA, and things can be what they call hemi-body neglect, hemi-auditory neglect, which really just goes with what we're saying. If you talk to them on one side of the room, they may ignore you completely, and then you go on the other side of the room and talk to them, and they are totally engaged with you. As far as these patients, they often have no awareness that they have deficits. So they may come to you and you look at them and their face is drooping. They're obviously paralyzed on the left side of their body. Maybe their eyes are even fixed to the left side of their body, and their report is, I fell. They don't know that they're paralyzed. They have no idea why they're here sometimes at all. And they may keep trying to get up and keep trying to move, and they're drooling, and they don't even realize what's going on with them. Often you will find these people have what's called motor neglect, and that may mean their arm may be in a really uncomfortable or unnatural position, such as under their body or stuck in the side rail, and they don't even know it. You would show them their arm by lifting it up, because usually they can't move it themselves, and say, whose arm is this? And they may tell you that it's yours, or that it's their mother's, or they'll say they don't know. You may also see them move this arm around spontaneously, but when you ask them to move it, they don't do it. Very complicated. Not to go over this in detail, but just so you have this, if a patient does get a 3 on the stroke scale, there is an automatic scoring that should be done, and pretty much you give them the worst score on almost everything. You do actually test them for gaze and visual by using the threat and moving the oculocephalic if able to, and you do also give them automatic 0 for ataxia and ataxia, but all others they get the worst score. The stroke scale does have some limitations, so although we find it very valuable, it does not replace the neuro exam. It depends how alert and awake and cooperative the patient is. So if they're really not involved in what you're doing, you will probably get some numbers that may not be reflective of what's going on with the patient's brain. It's highly weighted to anterior circulation strokes, and it's highly weighted to left-sided strokes. So the numbers may be much higher if they have a left-sided stroke or an anterior circulation stroke. So keep that in mind. If the stroke scale is 0, they could still have an infarct. And it's just really important that if they're having symptoms and complaining of symptoms that seem to be abnormal, to still keep stroke on your differential and rule it out. There are some symptoms that are not captured by the NIHSS, so you should be looking for these, and please reporting them if you're an EMS provider that's bringing them into the hospital. If they're complaining of headache, if they have nausea or they vomited, if they're complaining of dizziness, if they have truncal ataxia, which would mean, say, if they're sitting on the stretcher and you're noticing they're like leaning over about to fall off the stretcher. If they're just their hand or foot is weak because they may not have drift. If they lose sensation just to the hand, since we don't test that. If they have other memory loss that may not affect the orientation question or seems like they're just confused in general. If they lose vision in one eye only, because that is a stroke, and that's called monocular loss of vision, but it's not the type of stroke that is tested for on the stroke scale. They may also have loss of those vertical eye movements we mentioned earlier, and sometimes they're hoarse or their quality of speech is very breathy because they can't use their muscles properly. So you should also do a pupillary exam, look for other abnormal eye movements. If you haven't seen them walk, it's safe for you to have them walk or sit up straight, then you would observe the quality of that. Take it to their home and have them walk up to you and see that they're stumbling. If they hiccup, because that could be a sign of stroke, I mentioned hoarseness earlier, and then you should also do a little more formal strength testing because drift does not really capture full strength, things like squeezing the hand and pushing and pulling. You should also check muscle tone and if they're flaccid or not. So after going through all this, we're going to go through some common stroke symptoms related to some of the arteries that we mentioned. So the left MCA stroke is one of the ones we talked about a lot, and it's a very, unfortunately, common stroke syndrome. And so going through the stroke scale, you can see that it's quite a high number. These people aren't able to answer questions because they're aphasic, so they get 2 points for level of consciousness questions. They get 3 points for aphasia. They can't follow the commands because they don't understand what you're saying to them. They'll usually have a gaze preference. They'll have a visual field cut. They'll have paresis to their face and their arm more so than their leg. They'll have diminished sensation, or they could have a total loss of sensation, but something's going to be wrong probably with their sensation. And like we said, they can't really talk, so you do give them a 2 for dysarthria. You won't usually see signs of neglect in these patients. Sometimes it might be a partial MCA where one of the branches of the MCA is blocked, but not the entire thing. So fortunately, these patients do have more functions. But a lot of them are similar. So again, they can't answer questions, but this person can follow commands because their temporal lobe is spared and they do understand what you're saying to them. They just can't get out what they want to say. They usually know exactly what they want to say, and they're very frustrated. Again, their gaze could be affected. Usually their visual field won't be affected, thankfully, but their face and their arm and leg will again be affected, but the leg usually less than the arm. Sensation will usually be normal in these patients. But again, they probably won't be able to really communicate verbally with you and do things like reading sentences, and there's a good chance they may not be able to clearly speak to you. And this could be a superior division MCA stroke. We'll move on to the right MCA, which is a little less common. These are usually the patients that do come in and say, hey, I fell, do I have a broken leg? But they really probably have something more going on in their brain. Often they're drowsy, and it's really more so that they're not attentive. They're very distracted. They're not paying attention to what's going on, especially if the TV's on or they have 12 family members in the room. Their gaze can be affected. Their visual fields are usually affected. They often have hemiparesis to the left side, obviously, because this is a right-sided stroke, and have some sensory loss along with it. Again, like we said, it's quite common in stroke. They'll have some dysarthria, but neglect is really the big thing, and you see in these patients. So that's when you do the double simultaneous stimulation and look for that. Now, if they do have the complete visual field cut, you may not be able to score them for the visual neglect, so keep that in mind. And there are reference tools when you look up NIHSS on the internet that give you little caveats of things like that I've been saying throughout this, and I'll be glad to send it to you afterwards if you send me an email. Sorry. Left ACA stroke, that's the anterior cerebral artery that goes a lot to the frontal lobe. They're alert. They may answer questions right or they may not. They'll usually have a little facial paresis, and the bigger thing to notice on this is they're going to have more leg weakness than their face and their arm. And that's when you kind of say, hey, this looks like an ACA stroke. They can have some sensory loss, but it's probably going to also be that lower extremity more involved than the upper. And their aphasia may be different. It's the frontal area of the brain that's affected, and they have something called echolalia sometimes where they may just keep saying, hey, 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 hey. And they may even answer your questions and then move on to hey, 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 hey again. So that's a little bit more indicative of this stroke. The PCA, which is the posterior cerebral artery to the back areas of the brain, talking about the left here, we decided to do. So they could have some gaze problems. They usually more of a preference than a forced gaze, probably. They should have a visual field cut because this affects the occipital lobe of the brain, and the areas of the optic radiations are affected. Their face can be weak. They can have weakness to the right side of the body, since we're talking about the left, but it may not be near as pronounced as the MCA was. They can have loss of sensation. They can have trouble with fluency and naming, and they may have something called alexia without agraphia, meaning they can write, but then when you ask them to read, they cannot, and this would be really indicative of a left PCA stroke. And they may also have some trouble with their clarity of speech.
The next type of stroke we're going to look at would be a cerebellar stroke. We are looking at a right cerebellar stroke, but if it was a left cerebellar stroke, it would be very similar with just opposite side symptoms. As you can see, the patient has some motor dysfunction in their right upper extremities, but it's really just a bobble, or what we'll call a mild drift. They will have ataxia with their right upper and lower extremities, which would show that they are going to have quite a bit of difficulty with functions such as maybe holding utensils or even walking straight. They've got some loss of sensation, and they've got difficulty speaking clearly. So they only have a stroke scale of 6, but this could be someone who, once you try to get them up with therapy, could have quite a bit of disability and be what we call a disaster getting out of the bed. We'll move on to our mid-basilar occlusion, and this is one of the dreaded types of strokes that you really hope your patient does not have. They're going to have severe disability, and they're going to have a very high stroke scale, as you see, with a total of 25. They're going to be drowsy. They can't answer any questions. They may be able to follow the command for blinking because usually they do have some eye movements, but they can't follow any other commands because they won't have any other motor function. And as you see, they have complete facial paresis, inability to move their extremities. They'll usually have a forced gaze, and they will not be able to communicate, so they will get a 2 for both aphasia/language and dysarthria. They don't get a 3 for language because they were able to follow that one command. There are also small vessel stroke symptoms, which are also called lacunar stroke symptoms, and they're generally somewhat obvious with the ones that are listed below. So you can have a pure motor stroke, which should be self-explanatory, a purely sensory stroke. You could have a sensory motor stroke where both sensation and motor are affected. They can be a ataxic hemiparetic type of stroke, or they could present with symptoms of dysarthria and what we call a clumsy hand. We'll present one of these lacunar stroke syndromes on this last slide, where you see that it's a total of a stroke scale of 8, and you can see they've got some facial weakness, some left arm and left leg weakness, along with sensation changes and trouble speaking clearly. So this would be a sensory motor stroke, as mentioned in the slide prior to this. This is the end of the webinar. I hope it has been helpful for you in putting together the exam and being able to predict possibly things such as large vessel occlusions, what side the stroke is on, and where exactly the blood vessel might be. Again, here is my email. If you have any questions about this clinical presentation, I'll be glad to get back with you and hopefully be able to answer your questions. Thank you so much for participating.
On February 25th at 11 a.m., LERN Stroke Workgroup member Dr. Chuck Brunell will present our next webinar in our series titled Pre-Hospital Acute Stroke Management. Dr. Brunell is a board-certified emergency medicine physician by the American Board of Emergency Medicine and is the Chief Medical Officer of Acadian Companies, serving in this role since 2011. I hope you will join us for his presentation.